Good morning, good afternoon, and good evening. My name is Myra Betron. I am the Momentum Country and Global Leadership Global Technical Lead for Gender. And I welcome you to today's webinar on gender transformative approaches for preventing and responding to violence against women and girls in Nigeria. And I'm very excited today to hear from the wonderful lessons and experiences that we've had over the past 4 years. Those of us that have been working on gender-based violence for many years now know that this is truly a multi-sectoral issue that is linked not only to health, but also a range of development outcomes. It's rooted in social norms and cultural practices that pervade all levels of society, including the individual, household, community, and the power structures that govern these. We also know that because of that, this issue must be addressed from various aspects and through various approaches, yet rarely do programs have the opportunity to do that. So this program, funded by USAID in Nigeria under the Momentum Country and Global Leadership Project, really had a unique opportunity to be able to work at these various levels of the socio-ecological model to address and respond to violence against women. We're going to hear from the local actors that worked to implement this program today. But first, I'm going to hand it over to Momentum Country and Global Leadership's Global Project Director, Dr. Koki Agarwal, for some opening remarks. Koki?
Yes, thank you, Myra. I am Dr. Koki Agarwal, and I'm really honored to help join Myra in welcoming you to this important learning event, where we'll be sharing lessons and challenges from our work in implementing our gender-based violence programming in Nigeria. So Momentum Country and Global Leadership is funded by USAID and led by Jipaigo and partners and works in over 25 countries in partnership with governments and local partners, national and global stakeholders to accelerate progress towards maternal, newborn, and child health and reproductive health service outcomes. So addressing gender-based violence is very key to this mission. We know that gender-based violence is associated with poor reproductive health outcomes, including depression, disability, and sometimes death. And this is simply not acceptable. Our project is really proud to have been part of this incredible progress in Nigeria, alongside the strong leadership demonstrated by the government to shift harmful gender norms and prevent and address gender violence against women and girls in Nigeria's Ebonyi and Sokoto states. The project team used evidence-based interventions to address multiple drivers and factors that perpetuate gender-based violence, reproductive coercion, child and early forced marriage, and encourage early adoption of family planning. We also worked with 6 incredible community-based organizations to combat gender-based violence in their communities. And today you will hear directly from a few of those partners who will share how they will sustain the gains that were made through the project and continue to support the women and girls in their communities into the future. Today, we will also hear about the lessons from this important work. We will hear about the challenges, and we hope that this wide global audience that is joining us today will chime in and share what is working in your countries, in your local communities that we can learn from, and how do we continue to address violence against women and girls and improve their health and overall well-being. Promoting women's agency and freedom from bodily harm are basic starting points for promoting reproductive and maternal health. Gender-based violence is a very complex and critical issue that undermines these in many instances, and Momentum Country and Global Leadership has been able to position the health sector as a key player in addressing these issues in Nigeria. So I really want to thank you all for taking the time to join us and in this discussion today, and we look forward to your questions and comments in the Q&A and your contributions. I will now pass it over to Matsura Baba, who's the advisor for adolescent sexual and reproductive health in Nigeria for our project. Thank you.
Thank you, Koki. Good morning, good afternoon, everyone. I'll be introducing our speakers who will be taking us through the Momentum Country and Global Leadership implementation and also the strategies Next slide, please. All right. The first we have Dr. Chioma. Dr. Chioma is a public health gender development expert with over 19 years of experience leading and implementing health and social development programs. She's currently the project director, the USAID Momentum Country and Global Leadership, and also the director gender equality for JPIGO here in Nigeria. Next slide. We also have Nneka, who is the program management professional with over 16 years of experience. She's an advocate for children and also women. She's currently the state team leader of the Momentum Country and Global Leadership in Ebonyi State, Nigeria. Next slide. We have Dr. Zainab Alassan, who is the Social Behavioral Change Officer with Helping Hands Grassroots Support Foundation, one of the local implementing partners in Sokoto State. She's an advocate of gender and social inclusion. She's also the Assistant Director of Programs with Helping Hands. Next slide. Nwajiji Emmanuel is also an advocate of maternal and child health, youth wellbeing and social inclusion. He's the project coordinator at Essential Health for Rural Dwellers, one of the local implementing partners in Ebonyi State. Next. Last but definitely not the least, we have Barrister Faith Vane, who is a seasoned legal practitioner with over 17 years of experience. She has handled over 1,000 GBV cases in Ebonyi State, and she's currently the state coordinator, Ebonyi State Gender-Based Violence Task Force, and also the head of Gender-Based Violence Response Department with the Ministry of Justice in Ebonyi State. So they will be speaking across the implementation of the project and also some of the approaches that we have been able to implement. I'll hand it over to Dr. Chioma, who will be taking an overview of the project approaches, challenges, and also the impact of the intervention. Over to you, Dr. Chioma. Thank you.
Thank you, Mastura. Good morning, good afternoon, and good evening, everyone. Thank you for joining us for this webinar today. I am Dr. Chioma Oduenyi, the project director for the project in Nigeria. So today we'll be sharing learnings on how evidence-based gender transformative approaches have been successfully implemented in Ebonyi and Sokoto states in Nigeria. And we will underscore the major learnings and some challenges that we learned from addressing violence against women and girls. We will also be highlighting some lessons that we learned from several locally led approaches that we employ during the project implementation. As we go through the webinar, please don't forget to put down your questions on the Q&A box. At some point, we'll be able to take questions. Next slide, please. So to give a project overview of what the Momentum Country and Global Leadership Project was focused on doing, the goal of the project was to prevent and mitigate consequences of violence against women and girls and address drivers of child early and forced marriage, as well as promote early adoption of family planning. We had 4 objectives for the project. The first objective was to build local capacity of local organizations, host country institutions, service providers, to be able to deliver evidence-based quality gender-based violence services, including child early and forced marriage and family planning. The second objective was to increase access to and the use of evidence-based information and services to address intimate partner violence, sexual violence, family planning and reproductive health, as well as child early and forced marriage. We also had an objective 3 that focused on the use of adaptive learning across all of these focus areas of the project. We had a very important objective, objective 4, that focused on facilitating cross-sectoral collaboration and innovative partnerships among state and non-state actors to be able to address intimate partner violence, sexual violence, and child early and forced marriage. We implemented the projects in Ebonyi and Sokoto states in Nigeria. We supported 237 health facilities, and we had specific community interventions in 9 communities. The project was led by JPIGO in collaboration with Save the Children, Pact, and the Men of Group. In the 2 states where we worked, These project implementation activities were led by local organizations. In Sokoto, we had the Nana Girls Foundation, we had Helping Hands and Grassroots Foundation, we had Rural Women and Youth Development in Sokoto leading project implementation. In Ebonyi State, we had DoveNet, AQS, and Essential Health Network. These were the local organizations that led the project. And the project started sometime around October 2020 and is going through to September 2024. Next slide. In terms of technical approaches, we had two phases to this project. We started off with a formative assessment phase in the first year of the project, being that this project aimed at addressing preventing gender-based violence. We conducted a social norms exploration to identify the norms surrounding GBV, adoption of family planning, and child early and forced marriage. We also conducted a behaviorally focused applied political economy analysis to be able to identify local leaders' attitudes and behavior towards preventing and responding to gender-based violence. We worked with 6 local organizations, and in a bid to achieve our first objective, which is focused on building the capacities of local organizations, we applied integrated technical organizational capacity assessment to these 6 organizations to help them to identify where they were at the beginning, to be able to develop change action plans, which was measured at the end of the project. We also carried out a GBV services mapping, service providers mapping to identify what services were available in these 2 states for survivors of gender-based violence. After the formative phase, we went through a co-creation phase where we brought together stakeholders from different divides and designed the project's interventions based on the findings of the formative phase. Next slide. Next slide. So having completed the formative phase, where we identified gaps across those different areas that I have mentioned, we tailored the project's interventions across different categories. The first part, like I said, we carried out capacity development for local institutions, where we used ITOCA, the integrated capacity assessment tool, and organizational performance to identify the organizational performance index of the 6 local organizations. We also, we focused on increasing the capacity of multi-sectoral teams. In this part of the work, we were able to establish in support to state governments in these 2 states, multi-sectoral task force. And these multi-sectoral teams comprise of representatives of health, legal aid organizations, the justice sector, women's affairs, and law enforcement agencies to be able to strengthen multi-sectoral collaboration and coordination for response to GBV. The project had several community interventions. Like Myra said at the beginning, we layered the interventions across the socio-ecological model, where we attempted to focus on at every level. At the individual level, we were able to reach very young adolescents through the Choices program. We reached the parents and caregivers of the very young adolescents through the Voices program, and community members through the Promises program. So we had the Choices, Voices, and Promises, where we use sessions to engage all of these people on gender equitable attitudes and behaviors among very young adolescents, the parents of these adolescents and their caregivers and community members. We also used the adolescent sexual and reproductive health sessions to address older adolescents as well as their husbands, to also have conversations around improving their sexual and reproductive health. We had an evidence-based intervention called SASA Together, which we used to engage community men and women, as well as young people across the communities where we work, to understand men's power over women as the root cause of violence against women and how power can be balanced in relationships. We also implemented a couples communication program called Banda Behero, but we adapted it in Nigeria in these two states. In Ebonyi State, we had Uto Ezinụlọ, and in Sokoto State, it was adapted to Maorota Abunkoe. And this was to engage married couples who were less than 5 years in their relationships to improve their communications and their relationship. We also utilized the Women's Savings and Loans Clubs to engage community women, to empower them financially and economically to be able to contribute to their families and reduce their experiences of intimate partner violence indirectly. At the health facility level, we worked with over 200 facilities, like I mentioned earlier, to initiate screening for gender-based violence, identifying GBV cases through routine screening in these facilities, and providing post-GBV services to survivors of GBV. We also were able to give postpartum family planning counseling at the health facilities. We targeted the antenatal care and family planning clinics to be able to achieve this. Next slide. So just to throw more light on the capacity development work that we did with the 6 local organizations. In 2021, when the project started and we applied the ITOCA, the organizational performance index for these organizations were assessed on the scale of effectiveness, efficiency, relevance, sustainability, and resilience. And in 2021, all the partners' aggregated score was 1.5. And this is shown in this spider web on the right. In 2022, we repeated the ITOCA and we had the partners increasing in capacity, and they stood at 2.15. Then the final ITOCA that we did in 2023, all of these partners stood at 2.8. And this is demonstrating a lot of strengthened capacity for these partners. All the change action plans that they developed, they all completed their change action plan as the project is closing out. Next slide. So what are the lessons that we learned on this project? There are several lessons, but for the purpose of this webinar, we've just tried to highlight some of these. We learned that several community members are unable to recognize gender-based violence. And of course, we all know that there have been several years of harmful gender norms surrounded by the culture of silence around GBV. But when this project created these safe spaces where sessions were held to have these conversations, it's helped to increase the awareness of gender-based violence, as well as the consequences of GBV. And in turn, it stimulated these communities to begin to take collective action towards transforming those discriminatory gender norms that fuel gender-based violence. So it was important for us to have those conversations in groups of different groups, subgroups in the community to raise this awareness. Then in the health facility work that we did, we learned that effective and continuous supportive supervision is very critical. It's not enough to train service providers. We need to continually provide supportive supervision, continue to mentor the trained providers to ensure that they're able to provide quality services to survivors of gender-based violence. We also learned that stakeholder engagement is critical. So continuing to engage stakeholders across sectors beyond the health sector help to strengthen the collaboration and strengthen the multi-sectoral teams to be able to garner support from each other to provide the needed services for gender-based violence survivors. Having worked with local organizations on this project, we learned that these local organizations will always be at different levels at different times if they are being engaged in any project. So bringing them, helping them to increase their capacity to be able to transition whatever gains the project have made into sustainability phase it's critical, and helping them to establish their business case and sustainability plans and resource mobilization plans from the start of the project is very important, because once funding is cut, they also get affected. So, but if they have been able to establish resource mobilization plans and their business case, and they're able to continue to even do some of these activities at the end of the project to sustain the gains of the project, that's proved very helpful. There were, we also learned that several services lacked intentionality for including vulnerable population. For instance, women complained of not being able to pay for services around GBV. We also saw that in some cases, persons living with disability are excluded. So these are lessons for the future, why we design future programs in this line. So finally, we also identified that there was a big challenge around adaptation, because we needed a lot of time to be able to adapt some of the evidence-based approaches that we implemented. So being a behavioral change intervention, for future programs, we should take into consideration the required time before we begin to adapt some evidence-based interventions to ensure that whatever time the project has will be enough to see it through to the end. Next slide. So thank you very much for listening. I'm going to hand it over to the next speaker, Nneka. You have the floor.
Yes, thank you so much, Dr. Choma. I will be continuing with case study number 1, sharing on lessons learned in integrating gender-based violence, first-line clinical response into routine antenatal care and family planning services, as well as promoting early adoption of family planning in Ebonyi and Sokoto states. Next, please. So we used the following. Remember that we tested the feasibility, appropriateness, and acceptability of integrating gender-based violence into routine antenatal care and family planning services. And we used the following methodologies. Number 1, we conducted assessment for quality of GBV services in health facilities to check their readiness to provide services as in line with the minimum standard criteria. We also reviewed the health facility register to check documentation on GBV screening, GBV case identification, as well as service delivery. We also conducted post-service and reflection workshop in order to learn lessons learned, document best practices, as well as what worked and what didn't work. For feasibility, some of the experiences we had were limited resources, including shortage of staff. In some of the facilities we had few staff, like only one officer in charge with an assistant or a volunteer. So there was competing priorities as well as work overload. But over time, that improved. And then for appropriateness and acceptability, the healthcare providers experienced a lot of improvements in documentation and service delivery as a result of the trainings they have received on first-line clinical response training, as well as the information materials that we provided, like the job aid, the standard operating procedures, as well as GBV algorithms, all targeted at helping them to have a hands-on experience on how to do their work. Next, please. And so, continuing on the strategies that we use for integrating GBV in ANC and EPIC clinics, we use the following strategies. We conducted training for the healthcare providers who participated in the study, first-line clinical response training, focusing on screening, case identification, service delivery, and documentation. As I mentioned earlier, we also provided documents like guiding documents like standard operating procedures, job aids, algorithms that will be able to help them to have a hands-on reference on how to do their work. And then there were routine supportive supervision visit across the period of intervention to provide clarity and feedback and also improve on intervention. Referral directory was provided in order to improve linkages where services were not on-site available. And then there were quality improvement meetings, knowledge sharing meetings, pause and reflect meetings. All these were targeted towards improving service delivery, learning from implementation, and also improving on intervention. And there were also data validation and analysis to ensure that data collected, analyzed, and shared are of high quality, both the qualitative and quantitative data. Next, please. And so continuing on facility implementation, looking at persons faced with post-gender-based violence services, looking at the data on the screen, the bar charts, see the amber color is Sokoto and the red is Ebonyi. For Sokoto State, we reached 2,049 males and 16,094 females. And in Ebonyi, we reached 701 males and 5,439 females. Overall, a total of 24,283 persons were reached with gender-based violence survivor-centered services. Yes. Next, please. And so, continuing on youth and adolescent council on postpartum family planning, the strategies we used were training the healthcare providers, who in turn went on outreaches. The essence of the outreaches was to generate demand and improve the uptake of postpartum family planning. There were also norm-shifting sessions which happened at the community, counseling and linkage to service provision. Looking at the data on the screen, you will see that cumulative number of youth and adolescents counseled were 25,680 persons. Next, please. And continuing of postpartum family planning uptake by first-time mothers. If you look at the bar chart and the pie charts on the screen, you will see that the uptake of family planning, the methodologies that they used the most were implants and injectables, followed by Laxora amenorrhea. If you look at the red and the amber and the green shows a summary of how they assess different methodologies. And the cumulative number of first-time mothers who took up a method, both in Ebonyi and Sokoto State, were 1,377. Next, please. And I'll be handing over to Dr. Choma Odwenyi for questions coordination. Thank you.
Thank you, Nneka. And we already have a question for you here. So, and thanks to the person that, the people who are sending in their questions. So Nneka, someone is asking, who did the supportive supervisory visits? Were they officials from the implementing partners or their health service providers? I am asking this question because if the supportive supervision visits are done by the implementing partners, then once the project is over, the mentoring support and the visits also gets discontinued. Nneka, did you get that question clear?
Yes, absolutely. So the support supervision was done in collaboration with the state government officials from the Ministry of Health as well as Ministry of Women Affairs, who went together with the implementing partners also. So it was not a one-sided affair. We understood ownership as well as knowing that when the project has closed, that the state has to continue and service delivery has to keep happening. Over. Thank you. I don't know if I answered your question.
Chioma, you're
I'm
on
sorry.
mute.
I'm sorry. So thank you, Nneka, for answering the question. And just to add, our projects also work with the state governments to ensure that the GBV indicators that we were tracking got onto the integrated supportive supervision checklist. So this means that even as the project is closing out, the state officials are able to continue with, when they do the ISS, they're able to still look out for GBV issues at the facilities. And some of these, like Nneka has answered, officials were part of the supportive supervisory visits. So Nneka, there's still another question for you. So this person is asking, from a range of sexual reproductive health services, why did we focus on family planning, particularly postpartum family planning? What about HIV, STI testing and screening? Nneka, are you able to take on that?
Yeah, so you remember that gender-based, talking about gender-based violence, reproductive health, reproductive coercion is part of the type of gender-based violence that we are addressing. So that was what made us basically focus on family planning, especially encouraging women to take up a method of family planning immediately after delivery, knowing that women experience a lot of reproductive coercion, from communities, because in the beginning we had formative assessments, both we did service delivery mapping. We also did social norms exploration and other things that we did to assess the situation of things in the both states where we work, to be able to know what the issues are. Part of the findings were, how communities, mother-in-laws, extended family members, we are coercing women, mothers, to have more children, to have maybe have more boys or have more girls. And as a result of that, they're having issues. So that was why we focused on family planning. It doesn't mean that HIV is not a problem. We understand that both HIV, STIs, and others are public health issues, but the reasons I've mentioned are some of the reasons why we chose family planning. Thank you.
Yeah,
and
thank
also, we also provide, referrals at the facilities. It doesn't mean that if you go for only family planning or GBV services, if there are other underlying factors, we also make sure you have access to those services. Thank you.
Thank you very much, Nneka. In the interest of time, I will just quickly answer the question. Someone is asking how we use the ITOCA tool, if we customize the ITOCA tool to interventions for different agencies or different organizations. And I would say, yes, we worked, we had capacity development specialists sitting in our state offices, and they were going to the offices of these different partners to work with them. It was actually a self-assessment. So the partners were able to self-assess themselves based on their own needs and develop their own change action plan. So each organization was, the ITOCA was used for them with them. So we are going to be moving to the next case study. And I will be handing this to Emmanuel. Emmanuel. Oh. Oh, Zainab, please go on.
Yes, ma'am. Okay. Good morning and good afternoon, all. I'll be taking us through the primary prevention of GBV through community mobilization interventions in Ebonyi and Sokoto State. Next slide. Yeah, we're going to look at the first intervention, that is SASA Together. SASA is a community mobilization strategy that focuses basically on preventing violence against women by addressing the root cause of violence, as well as looking at the power imbalance between men and women, both at the community and the individual level. SASA intervention was in 4 phases, and these 4 phases are based on the stages of change, and these stages of change also use different powers. So for the first stage, that is the start phase, we use the power within, and the awareness phase deals with power over, while the support phase use power with, and the last phase, which is the action phase, also deals with the power to. Now, the intervention commenced in 2022 with the adaptation and training of activists and community leaders, and also some stakeholders in the state. And after the intervention, immediately after the training and the adaptation of the SASA materials, the intervention followed immediately with the activists and leaders conducting reflection sessions with community members and also community leaders using the SASA materials like the power poster, community conversation, to mention just a few of these materials. For the intervention in Ebonyi and Sokoto, we have successfully completed the start and the awareness phase, while the support phase and the action phase is currently going on. Next slide, please. Next slide. Now, if we look at the charts here, we see the number or the cumulative number of persons reached with SASA in both Ebonyi and Sokoto State. For SASA, we're able to reach a cumulative number of 39,247 persons for both states, out of which we have 54% being male and 46% female. Now, from the reflection sessions that we have, and also the interaction with the community members and leaders, with the activists, we now have some significant changes and testimonies from participants and those that benefited from SASA. And I'm going to take just but one from the numerous quotes and testimonies we had from our participants. Now, for this participant from Ebonyi, who is a beneficiary or a participant of the SASA intervention, said, "Before now, I don't know that I was using my power negatively on my family members, especially the women. But after I came in contact with SASA activists in my community, I participated in 5 sessions facilitated by the activists, and thereafter I had a deep reflection on how I use my power and decided to change and began to use power positively without hurting anyone of the women in my family." Now, this is a quote from one of the participants as a result of his experience in the SASA intervention. Now, next slide, please. Now, the second intervention is Bandavarehu, which is Ma'aurata Abunkoyi in Sokoto, and Utoize Naulo in Ebonyi State. Is a couples communication intervention that engages men in discussion on RMSCH and also violence prevention, and also talking about healthy relationship among couples. Now, the intervention focus on newly married couples of age 18 to 35 for both states, that is Ebonyi and Sokoto. Now, these women of age 18 to 35 were engaged in a session for about 16 weeks, and it lasted for a period of 3 to 4 months. Now, during the session, the participants were taken through a module, and in this module, they were able to interact and discuss deeply where these people experience significant changes in the way they relate with the family, the way they relate with their children, and how they treat their wives with respect. Now, from this intervention in Ebonyi State and Sokoto, we targeted about 84 couples, 48 from Ebonyi and 36 in Sokoto. So we had a total of 84 couples that were reached with the intervention of Bandabareho, that is Maurata Bunko, out is a new law in Ebonyi State. Now we also, next slide, please, before the next slide, we're going to look at a quote. Please, can we go to the previous slide? Yeah. Now there's a quote here from a participant from the Bandabareho session after having experienced all the sessions during the intervention. We have a quote here from one participant said, before the intervention of Maarota Abunkoyi, we are good in entertaining our neighbors through physical violence, particularly fighting and abuse. I beat my wife at any slight provocation, and she talks back at me without regards. When we had discussion about gender-based violence, I felt guilty of all I treated my wife. I made up my mind to turn a new leaf. I don't beat my wife again. Instead, I call her attention and we will sit down and sort things out. We do chores together. That is a quote from a participant from Sokoto. Now the next intervention, next slide. Now this intervention is the Women's Savings and Loan Group. This is a community-based initiative where women are empowered, to help themselves get financial security. And this intervention in Sokoto and Ebonyi, we had about 60 groups for this intervention. The women meet weekly to contribute, and this contribution they made is being given out to participants or group members as loan to start up small-scale businesses. And these participants, after being given this loan, they set up business, after which they generate income, and this income they use to support themselves. For Ebonyi and Sokoto State, we had about 60 groups, 30 in Ebonyi and 30 in Sokoto State. And these groups have about 25 women as members. So in all, we had 1,500 women that benefited from the Women's Saving Loan Group. And this is one of the quotes from a beneficiary of the Women's Saving Loan Group who testified of how she benefited or what are her gains from participating in the Women's Saving Loan Group. She said, I have benefited from the Women's Saving Loan Group because I am now a proud owner of my own petty trade, and I can take care of some of my needs, e.g. buying my drugs, buying books for my daughters, as well as supporting my family because I have a little amount to contribute. My husband now seeks my advice in making a decision. Now, these were some of the interventions that we carried out in both Ebonyi and Sokoto State during the MCGL GBV project. Now I will hand over to my colleague, Emmanuel, to continue with the next presentation. Thank you for listening.
Chioma, I'll turn it over to you. We have a few to get started with, and when Faith, Ben, and Emmanuel are with us, we will look forward to learning from their sections.
Okay, so thank you, Caroline. So Zainab, you've got some interesting questions here. So someone is asking, during these sessions, were community leaders and religious leaders actively involved so that after the intervention, they can further educate the community members on GBV? Over. Zainab.
Yeah, okay. The community leaders actually form part of the activists because they were also trained on this. And the community leaders also were among the CBOs because we are able to establish a CBO. And these CBOs, the community members form part of it. And they are also among the monitoring team that we also established to monitor the activities in the community. So they are actively involved in the intervention. Thank you.
Okay, thank you, Zainab. And someone else is asking, can you share a bit on the impact of SASA Together?
Oh, okay. For SASA Together, we had a whole lot of testimonies from couples because the start phase and the awareness phase that have been completed. Now people are beginning to talk about violence in the community. People now know that they have power within them. They have that potential to speak out about violence against women in their community. And the awareness phase, now people also now are aware. They are beginning to think around making some effort to see what they can do about, enlightening people more on how to address violence against women, because the awareness phase has to do with the community silence and analyzing the power of men over women. So that is what the community are now talking about as it is. And as we've said in our presentation, that is support phase and the action phase is ongoing. And with the support phase, the activists will they will identify those that have this good intention of changing and refer them to where they need to get this support that will help them to address some of these norms that encourage gender-based violence in our community. Thank you.
Okay, thank you, Zainab. Maybe we'll just take one more question from you, then we can move. For you, so someone is asking, I know in Sokoto, there exists in some LGAs, gender-based violence surveillance team.
Yes.
Are they included in the project capacity building initiative to increase GBV reporting from communities to health facilities and the states for medical and other services?
Yeah, like in Sokoto, we have the state response team, and we also have on ground the multi-sectoral team in all the LGAs we work in. And this multi-sectoral team work hand in hand with the state response team and the Ministry of Women Affairs, and hand in hand they work, because we also have the GBV plan that the multi-sectoral team have come up with, which was duly signed by the LGA chairpersons, and the Ministry of Women Affairs is aware of that. So these are some of the platforms where they work together and try to see how they could, kind of limit or minimize what the issues of gender-based violence in Sokoto State. Actually, we're working hand in hand with the state response team. Thank you.
Thank you, Zainab. Thank you very much. I see that Emmanuel is back here, so we can move back the presentation. Emmanuel, please, you have the floor.
Okay, good morning, good afternoon, everyone.
We
Sorry
can
for that
hear
technical
you.
issue.
Proceed.
I'll be making, can you hear me? Hello, can someone hear me?
Very well, very well. Proceed.
Okay. I am making presentation on addressing child early and forced marriage and early adoption of family planning. Thank you. The next slide, please. Okay, this presentation is looking at the ecological models that was employed by MCGL to address gender issues in Ebonyi State and Sokoto, where we implemented. And here we'll be looking at choices, adolescent sexual health, voices, and promises. In promises, this is an approach that allowed parents of adolescents to learn about gender transformation and equitable distribution of chores for their children, both girls and boys. For voices, this also promoted gender equity and division of labor for their wards as well. Now, for the churches and us, the churches looked at very young adolescents and older adolescents, 10 to 14 and 15 to 19 of age, where they were engaged on a weekly basis for them to learn gender transformation on how they can have a better life and better future. Some of the outcomes of these interventions were that parents pledged to support education and challenge harmful practices that were demonstrated during the interventions. Parents also reinforced lessons, improved communication, and strengthened bonds between facilitators and families, sustaining positive changes in households and communities. Also, communities formed task force to address issues like early marriage and 15 adolescents menstruating back to school in Sokoto, and ongoing arrangement for child early and forced marriage stopped for up to 10 girls in Sokoto State. Girls and parents now agree that it is not a shameful thing to wait until they are 18 before they get into marital life. Next slide, please. Okay, this is a chart representing number of persons that was reached during this intervention. We cumulatively reached over 2,816 adults, parents of adolescents, very young adolescents and older adolescents, and community members as well. Next slide, please. These are some of the quotes from the intervention. This is a quote from a choices participant in Ebonyi State. It says, "In my community, it is very common for parents to send out their daughters into marriage. But through this program, and I will ensure I stay in school and complete my education. I will also make sure not to get to school so they can have a good education." This is a quote from a very young adolescent choices in a bed, please. So these are some of the lessons learned during the intervention from the families and communities as well. Prior to this intervention, many adolescents, parents, and community members didn't consider and value their daughters' education and instead prioritize boys. However, now they share their desire and plans to enroll and retain their children, particularly their daughters, in school. With local partners, organizations, experiences, and long-standing relationship, they were able to identify and reach the most vulnerable and hard-to-reach communities with key interventions, and community members perceive locally led intervention as culturally appropriate, respectful of their autonomy, and more acceptable. It goes a long way to show that we that were in the community played a very important role in ensuring that we led and were able to achieve the success for the intervention in all. Thank you. Next slide. So the learning continues. Engaging community leaders in participating in safe space selection, which enhance acceptance and sustainability, and future intervention should focus on strong community involvement to maximize impact. The safe spaces that was used during this intervention were facilitated by the community members, and this goes a long way to show that we had the interest of the young adolescent at heart and gave them free will for them to join and also air their views on how they can better their life. School teachers were also regarded and deemed role models among community members, and engaging them facilitated greater acceptance of adolescent-focused health and gender equality intervention. A positive unintended outcome of the intervention was also increased school enrollment and retention of in-school and out-of-school adolescent girls and boys. Next slide. Okay, thank you.
Yes, so Emmanuel presented on the choices, voices, promises that and ASRH interventions that targeted very young adolescents and older adolescents. It can be taken to scale. As a matter of fact, the project started having the sessions with fewer adolescents. We started with engaging about 200 adolescents, then we took it up to 700 and got up to over 1,000. So once you have the resources, it can be taken to scale and it's replicable anywhere around the world. And as a matter of fact, these are already evidence-based interventions that have been proven across several settings. I hope that answers that question. Thank you. Faith, are you ready? Can we move to Faith's presentation now?
Good morning, good afternoon, everybody. I will be speaking to multi-sectoral coordination and collaboration of GBV, that is gender-based violence response, that MCJL worked on in both states, that is Sokoto and Ebonyi states. Multi-sectoral task force, as we all know, or multi-sectoral response is just a coordinated approach to address GBV that involves multiple sectors, agencies, and stakeholders. And so they say, I can do it all. There is hardly a one-stop center to mitigate against or fight gender-based violence. And that is why we believe that it should be a holistic approach. It should be a kind of a comprehensive approach. And so we gathered people from the law enforcement agencies, that is the team composition of the multi-sectoral. We gathered the law enforcement agencies like the police, civil defense corps. We brought in the government people, like the Ministry of Justice, Health, Education, and the Social Welfare, the representatives from the office of the local government areas of both states that MCJL worked in. And we equally brought in the health care workers. We brought in the CSOs, the CBOs working in those local governments where the multi-sectorals, where MCJL worked in. And we brought in the religious leaders, traditional leaders, women leaders, as well as the youth leaders. In fact, it was a holistic approach where every hand was, on deck fighting the menace of gender-based violence. And so the interventions done by the Momentum Country Global Leadership Program has, equally helped in establishing and facilitating the reactivation of multi-sectoral task forces across 22 Momentum-supported local government areas in Ebonyi and Sokoto states. These were where they intervened. What they did on arrival was they conducted capacity gap assessments, to actually know what we need and what were those things that they need to build up around as a support by way of technical or otherwise. And so when they were able to do those things, they carried out capacity building, including smart advocacy training and support, and advocacy support. And I want to say that the smart advocacy that was carried out was it was a top-notch, and the response team of both states where they worked in Ebonyi and Sokoto, the smart advocacy training was a whole lot of learning for us. We were able to, be taken through that training to know how we can even engage the government, engage the religious leaders. Were taught how to engage the traditional rulers and all the stakeholders. And so after learning that, going through that training, and we went into a whole lot of advocacy visits to agencies here in Ebonyi State and equally in Sokoto State. We were able to visit, and as a matter of fact, we were able to establish in some establishments where we needed to have gender desk particularly in Ekweme Teaching Hospital in Ebonyi State. We were able to establish a gender desk as a result of the advocacy visit that we had in that place. And up until now, the center is running very, very well and very strong, because before then, we were only having where we call NOFIC in Ebonyi State, and one other center there in Sokoto. And because after the smart advocacy training, we have been having it so good around those issues. Next slide, please. Strengthening the multi-sectoral task force teams had led to enhanced collaboration between local government multi-sectoral task forces and state GBV task forces, resulting in improved referral systems and better case management. The multi-sectoral task forces have successfully referred GBV survivors from the community to the health facilities to post-GBV clinical service provisions. Each multi-sectoral task force in Ebonyi and Sokoto State developed a 3-year GBV action plan to guide the implementation of prevention and response activities. And again, the multi-sectoral task force is begun integrating child force early marriage prevention and response strategies into their work. We've gotten increased awareness and sensitization about GBV. The channel of reporting and post-GBV services service is so much available in the communities now. Thank you so very much for listening. Thank you.
Thank you, Faith, and thank you, everyone, for your very concise, but certainly not sufficient explanation of all the rich and wonderful work that you accomplished over the past 4 years. We have a number of additional questions in the chat. If anyone wants to go in to respond to some of the Q&A, I'll try to help address some of them with this roundtable with our panelists. I'll start off with a question for Emmanuel. And this was also a question that was raised someone in the Q&A box as well, around how we use the findings from the formative assessment to inform the design of the program. I'm not sure if it was very clear, but this program did go through a co-creation phase using the results of formative assessment, and that process took 1 year. So there was definitely a very careful process that we undertook. Emmanuel, do you want to speak to how those findings were used to inform the design of the program, and whether the design conceptualized this use of the socioecological model from the beginning, or was it the results of the assessments that helped inform that? I know Emmanuel's having challenges with his sound. Chioma, do you want to help with responding to this question, since it actually was directed to you originally in the chat?
Project, after the 1 full year of formative assessments, all the findings of the formative assessment were taken to a co-creation phase where we invited all the stakeholders across sectors, including religious leaders, traditional leaders, government officials, state and non-state actors, and we came together and designed the project intervention. So this was extensively spoken about at the beginning. Yeah, Myra, I guess that was the question, or did I miss any part?
Yes. And did you respond to whether, the socio-ecological approach was something that we actually started out with from the beginning, or if that was a result of the formative assessment?
Oh, it was the result of the formative assessment, because from the formative assessment, like we did social norms exploration, where we found normative and non-normative factors, and we're able to use our gender theory of change, which is focused on the socioecological model. And we were layering the socioecological model components from the individual level, relationship level, community level, service delivery level. So The MCGL overall gender theory of change is also anchored on the socio-ecological model, and these findings, when we now tailored interventions to the findings from the formative assessments. Over.
Great, thank you, Chioma. I'm now going to move to Dr. Zainab. We had a number of questions around the sustainability of the interventions as well. So could you tell us, with these notable outcomes that the project achieved, especially around increasing school enrollment and retention for adolescent girls and boys and ending child early forced marriage, how did the project ensure these changes were sustainable? And what mechanisms were put in place to maintain these beyond the life of the project?
Oh, okay. For to maintain this, using the local partners, that is to be specific and precise, Helping Hands and Grassroots Support Foundation, we established a community-based organization, CBO, that is registered as the Jinkai Community Development Initiative. And this CBO have facilitators, activists, community leaders as members. And the CBOs are also those that implemented the intervention. So with the CBOs, we are able to continue with all of these activities, and we're able to maintain some of this intervention, because right now the CBOs have a work plan that they are working on, and in their work plan, they have some of these activities embedded in it. And in addition, we also have we as an organization, we have also taken the responsibility to kind of support the adolescents that were mainstreamed back to school as a result of their participation in the CVP sessions. Those that were mainstreamed, so we do through our educational intervention program as an organization, we see to it that we support this adolescent to remain in school, while we also work with the school-based management committee and parents, that is the PTA, and the community leaders also, to ensure that these girls remain in school. It's also in the intervention, like the CVP, we have the promises part of it, where parents pledge that they will support their children to continue their education. So in doing that, the parents also were being carried along, parents of these beneficiaries and those that were mainstream back to school. So these are some of the aspects. And we also have the multi-sectoral team that are also playing a very important role. They are on ground, fully on ground, and they work closely with the Ministry of Women and Children Affairs, and they also support the activities of these CBOs, helping them to implement their plans also. And this multi-sectoral also intervene. In some cases, we have, like in Sokoto, where we have instances of girls that are being forced into marriage, so, but with the intervention of the multi-sectoral task force, we, in collaboration with the response team, we're able to manage such cases. So these are some of the mechanisms on ground to sustain this in Sokoto State and across to Ebonyi State. Yeah. Thank you.
Thank you so much. And on that point of the multi-sectoral task force, Barrister Faith, if you are able to come off mute, do you want to respond to any sort of sustainability actions that the program helped support with the multi-sectoral task force or through the multi-sectoral task force?
Yeah, the GBV action work plan is there, and that is a document that is recognized by both the state government and the local government, because it was duly signed by the chairpersons of the local government. So it's on this plan that is on ground for them to use the continued awareness creation on the gender-based violence and other activities in their communities.
Okay. And Faith, did you want to add to that at all?
The VAP law is a very serious tool of implementation. And in our various states, the VAP law has remained a very veritable tool, and we are really, really leveraging on it. Actually, we equally have the referral pathway mechanism that MCJL helped us to develop, and we are using it. And in fact, it's very, very effective. It has really been helpful. Another sustainability plan, or that is already on ground, is the enabling environment by our various states. Working on responding on issues of gender-based violence is becoming a kind of a little bit seamless because of the provisions under the VAP law. Again, we have entrenched into the VAP law the budgetary plans or allocation for activities of gender-based violence. And what we just need to keep doing is to keep engaging the stakeholders to do what they have to do in line with the law. That is it.
Great. Thank you so much. And I think, there were some questions and comments that really speak to the need for continuing support and resources. Do you all think that you've had enough time to work with various groups to ensure sustainability? This is obviously a very complex program. You've spoken already about some of the actions taken to allow for continuous work and sustainability. And we didn't even speak much in the presentation about the rich work that the program did to support the development of policies and action plans. So thank you for mentioning that in your comments. But I think it would be great to understand, Chioma, do you want to share some reflections about sort of the lessons around sustainability, as well as the overall lessons that you think that can be carried forward in the future as the government and local actors move forward in implementing?
Okay, thank you, Myra. And we have all heard from all the presenters the depth of the work that has been done on this project. And the project is winding down, and it's time, we are transiting to our responsibilities, what we've been doing in these years, over to government and other community-based organizations to lead. So, and they're already doing that. So it's some of the key lessons for the future would be that we've seen that breaking the culture of silence around gender-based violence requires ongoing and sustained engagement. We have to continue to engage with community members through proven strategies like we've demonstrated through this project. Some of these strategies are effective. They will help individuals, they will help families and the communities to be able to recognize gender-based violence, because that's one of the challenges we saw from the beginning. People not being able to recognize GBV and call it what it is. And now the communities are empowered to easily recognize it, and now have the capacity to take collective action to prevent and mitigate GBV. So this is a big consideration for the future. It's also important that to underscore the fact that we were able to integrate GBV across family planning and ANC clinics, and it proved to be effective. So we should continue to consider ensuring that GBV services are integrated across all health interventions. Then, of course, the multi-sectoral collaborations cannot be overemphasized. We've learned that we cannot continue to work in silos in this space. And for us to be able to effectively address violence against women and girls, we must join forces to respond effectively to the needs of GBV survivors. The local organizations who have led part of this presentation today have also demonstrated that they're able to lead some of these programs if we give them enough support. So finally, I would say that as we all continue to push for integrated services across the health sector, we must also understand that addressing violence against women and girls also require as much resources as other interventions. So it must be holistic. Response activities must be paired with prevention activities when we're designing future interventions. So thank you, Myra. I hope. I
Yes,
answered
thank you
you.
so much, Chioma. And there's certainly so much more we could say about the work that's been done. We will be publishing a number of briefs and reports to share in more detail how these interventions were implemented and all of the rich lessons from those. So please stay tuned for those. They will be published on the Momentum Country and Global Leadership website. Going to hand it over now to Dr. Gertrude to give some closing remarks.
Thank you, Myra. Good morning, good afternoon, everyone. Like Myra said, I'm Dr. Gertrude days ago. And on behalf of the USAID funded MCGL program and team, I'd like to thank all of us for taking the time to participate in this engaging and enlightening conversation. At USAID, we believe that deliberate action is required to advance gender equality, and we are committed to being a leading partner and advocate for gender equality and inclusive development. We appreciate the efforts of all the relevant stakeholders, from governments to our local partners, healthcare workers, to the community structures, and even the survivors themselves, for the success of this program. So, but while this particular program is closing, let's see this as a call to action for everyone to keep the fire burning. It has to be a collective action of whatever efforts and contributions that we can put in, no matter how little, if we must halt the evolving consequences of gender-based violence and help everyone enjoy their fundamental human rights of freedom from every form of violence, including violence against women and girls. I'd like to use this opportunity to thank JPIGO and its partners for leading this important work on behalf of USAID in Sokoto, Ebonyi, and Nigeria at large. The lessons and recommendations, contribute to our continuous learning and adaptation efforts. We sincerely look forward to our continued work and collaboration in this area, working with various stakeholders in Nigeria. And as I can imagine from the length and breadth of the participation in the room today, I can imagine that some lessons will be taken to other countries, so let's keep the flag flying, let's protect as many persons, especially women and girls, as possible. Thank you so much. Over.
Thank you very much, Dr. Gertrude. And thank you. Let me also still join Dr. Gertrude to say thank you to everyone that have joined us today. We appreciate that out of your busy schedules, you were able to be part of this conversation. Please, some of the questions that we're not able to answer, I think some persons have tried to answer on the chats, but in case we are not able to answer your question today, feel free to still reach out to us. We'll be glad to do that. However, sorry, go back to the slide. Yeah, so please, the link on the chats, please take some time to complete our webinar survey today. I think that is it from us. Thank you everyone for participating. Bye from us.